This is part 4 of the Specialized Nutrition Support presentation series for Skills Lab. And at the end of session 3, we were talking about the electrolytes that are typically added to a TPN. So again, here is the list of the most common ones and some of the ranges. One further note about these ranges are max numbers here. The reason we try not to go much higher than this is there's a lack of stability data, so we really don't know if adding sodium to 170, 180 milligrams per liter, in addition to all the other components, is really a compatible amount of sodium to put in there, so it could lead to precipitation or other problems. And a lot of times I get asked the question, well, how do we manage the TPN or electrolytes? How do you know how much to go up on the potassium, down on the chloride? When do you add phos, take it out? And so TPN management, especially the electrolyte management, is very complicated. It's really above the scope of the Skills Lab. That's the kind of information you'd learn on maybe IPI, but definitely an API type of nutrition support rotation. So don't feel too bad if you're uncomfortable or still just don't get the whole management component of it. That's normal and to be expected. That comes with experience and really just working on many TPN patients and making the adjustments and talking with other people and kind of seeing what the effect of your change makes on the patient the next day. So just a few more things about the electrolytes. One thing is, a lot of times say, well, how do you know how much chloride or acetate salt? Because we've got sodium chloride, sodium acetate, potassium chloride, potassium acetate. And typically, if you can keep your ratio of chloride to acetate kind of on a 1-to-1 ratio, you're doing okay. We sort of veer away from that 1-to-1 ratio only when needed, and it's usually only needed if there's some type of an acid-base imbalance. So for example, chloride is an acidifier. So if somebody has metabolic alkalosis, for example, from high nasogastric tube output, it's good to replace some of that chloride that they may have lost from the NG tube via the TPN. And since it's an acidifier, it will help sort of neutralize the alkalosis that the patient's experiencing. And same thing for acetate. Acetate is converted by the liver to bicarbonate. So we know bicarbonate, more of an alkalinizer. So if somebody has metabolic acidosis, like from diarrhea or acute kidney injury, acute renal failure, then acetate provided via the TPN can actually help with the patient's metabolic acidosis. Another common additive in TPN bag is the vitamins, multivitamins. And this is what usually gives it that yellow kind of color or tint to the solution. Some people, if it's just a IV bag, like normal saline with multivitamins, it looks very similar to a TPN, and sometimes we call that a banana bag just because it's kind of a yellowish color. But one brand name of multivitamins is MVI Adult. As you can see there, sometimes they include vitamin K, sometimes they don't. You have to specify which product when ordering it, and it's good to be familiar with which product your pharmacy is adding to the TPN bag. And typical dose for adult is about 10 milliliters per day to provide the recommended daily allowance of all the fat-soluble and water-soluble vitamins. Same thing for trace metals. These are things like chromium, copper, manganese, zinc, selenium, and typically 3 milliliters per day will provide or meet the patient's needs for those trace metals. And this is very common to put both of these multivitamins and trace metals in a patient TPN, every patient's TPN every day. Not everybody's going to need those trace metals, especially in the short term, but in the long term they will. So if the patient ends up being a long-term TPN, it's hard to predict sometimes, then you'd be thankful that you started putting those in there on day one. Some other additives that we commonly utilize in the TPN are various drugs and other supplements of vitamins. H2 blockers, heparin can go in the TPN, but we typically only do that for bone marrow transplant patients. Hydrocortisone is good to add to a peripheral parenteral nutrition solution or a peripheral TPN because it kind of gives an anti-inflammatory protection to that peripheral vein, prevents the phlebitis that's so common with peripheral TPNs. But there's no reason to put that in a central vein TPN. Then if somebody has a history of alcoholism or maybe they're critically ill, we typically supplement their thiamine and folate, as you can see there. And people with diarrhea, fistulas, they can lose a lot of zinc in those, the diarrhea or the fistulas, so it's common for us to supplement that with an extra 5 milligrams a day. And that zinc supplement would be on top of, going back one slide, the zinc that is in the trace metals, which is only about, I think, 1 to 3 milligrams. So a little extra zinc for those folks. And then insulin only if they're have glycemic problems. For example, glucose is over 180 or over 200. We don't even put it in there if it's 130, 140 milligrams per deciliter. Wait till it gets fairly high, and then we'll start adding the insulin. And if you find yourself needing to give more than 50 units of insulin per liter of TPN, that probably tells you there's something else going on, and you really need to address the underlying problem. Maybe you're just giving too much carbohydrate in your TPN, or they need maybe a basal type of dose of insulin on top of that. So next thing, now we're going to start the TPN. We've calculated the formula. We know how many kcals we want to give and how many gram amounts of the macronutrients. We've got some electrolytes and some other drugs in the TPN bag. So the important thing is start low and go slow. So on day one, we can take our time and get to the goal rate. TPN is not a medical emergency, so we've got time on our side to sort of start low, go slow, and make sure the patient tolerates what we're giving them. Again, this is a fairly risky medication therapy that we're giving, so it's best to be cautious. So on day one, there's multiple ways to accomplish this start low, go slow theory. But typically what I like to do is start half the goal rate. So if my goal rate is 75 mils per hour, I might start the TPN at 40 mils per hour. If they do okay on that, I'll crank it up to about 60 the next day. And then by day 3, if everything's still going okay, looking at their volume status, urine output, their labs, finger stick glucoses, so on and so forth, all the monitoring, then I'll take them up to their goal by day 3. And that's certainly fine to do. Again, it's not a medical emergency. You don't have to get them to goal overnight. But every once in a while, we do kind of start people at the goal rate. But this would only be for somebody who's at very low risk for refeeding syndrome. And refeeding syndrome comes into play when somebody hasn't eaten in a long time, or if they're already malnourished or have some other disease going on. If the patient's already been getting dextrose in their IV fluid, like through D5LR, D5NS, or if they've been eating up until fairly recently, then they're at low risk for refeeding syndrome. And of course, we would make sure all their laboratory values and other parameters were normal before starting at goal rate. So that's really the exception to the rule. There's no reason to do that other than convenience sometimes. All right, so we've started our TPN, we've infused it. Let's say the patient started eating again or has received maximum benefit from the TPN. And for whatever reason, it's time to stop the TPN. We get this question a lot too. Oh, do we have to taper it off slowly, like a little bit, per hour, and it's going to take 2 to 3 days to get TPN off? And that's just not true. You can actually stop a TPN fairly quickly, but you don't have to just shut it off abruptly either. So this is the formula I like to use and tell the doctors and nurses. So if it's time to stop the TPN, we say cut the TPN rate in half from whatever it is, cut in half to half that rate, and then 4 hours later you can DC the TPN completely, and that should be adequate. And the thing we're being cautious with here is we're trying to avoid rebound hypoglycemia, and that occurs if the body is receiving carbohydrate or dextrose at a high rate. The insulin responds to that by secreting insulin. But there's sort of a lag in that whole chain of processes. So if you abruptly stop the dextrose infusion, the pancreas is still going to make some insulin, release it, so on and so forth. So by the time it gets to the bloodstream, it doesn't actually realize you have stopped the dextrose infusion. So that amount of insulin that it just secreted, right as you stop the infusion, can be a little too much sometimes and cause hypoglycemia. So what we can do is follow this prescription I outlined up here, and then check a finger stick glucose 1 hour after you've completely DC'd the TPN. And as long as it's greater than 70, you're okay. If it's still really low, I mean, if it's lower than 70, you can hang a little bit of D10W at a low rate, and that's usually adequate to transition the patient off TPN to D10W for maybe another 2 or 3 hours. It will be adequate. Okay, just a quick note about fluids, how we estimate fluid needs, and there's multiple ways to do this, and this is fairly complicated as well. I'm going to give you a very simple way of just kind of get you in the ballpark. So there's a formula, for example, for an adult, you could do 1,500 mils plus 20 mils per kilogram for every kilogram over 20 kilograms. A little bit easier way for me is just usually use 30 to 35 mils per kilogram per day. So this will come up being somewhere between 2,000 to 3,000 mils per day. And then we have the question, or we have to make the decision, do we provide all the patient's fluid needs through the TPN bag, or do we kind of do a split where we give a portion of the fluids via TPN and then a little bit more on the side from an additional IV fluid. So essentially the patient would have 2 infusions going into the body at the same time. One is the TPN bag and the other is the IV fluid. So let me give you an example of what I'm talking about down here. If we do the calculations and we estimate patient's total fluid needs are 3,000 milliliters per day, one strategy would be to give 2,000 of that as TPN and the remaining 1,000 as half normal saline. So TPN would go at 84 mils per hour, half normal saline would go at 42 mils per hour. At the end of the day, these 2 rates going in at the same time continuously will give the patient 3,000 milliliters of fluid per day. And I like to do that just in case the patient's fluid needs change. It's a lot easier to go up or down on this half normal saline rate than it is to be changing the TPN rate, because the TPN rate is calculated after several steps that we went through earlier to come up with a very specific number of calories and gram amounts of macronutrients. So once you change that rate, you're changing the amount of nutrients delivered to the patient and electrolytes. Think of it this way: the normal saline is a much more innocuous fluid vehicle to give the patient. So you can go up and down on that all day long and it doesn't matter, and it's essentially there's no cost involved with that other than the nurse having to go in there and change the pump. TPN's a much bigger deal to be changing the rate on. And here's just a picture of a typical TPN compounder, as we call it. It's got the computer and some of the other instrumentation and mechanics. And so these are probably your macronutrients over here, electrolytes, vitamins, so on and so forth, other drugs that the machine pulls in from the bulk bottles or stock bottles through the tubing, and then we'll inject that into an empty bag to create a TPN bag over here. That might be actually what's hanging up here is a completed TPN bag. So a few things to note that are important are the complications of TPN, and we're going to continue this with the next session.